Welcome to the first episode of the Reverse IM Board Review, and we're going to start with cardiology. First part, physical exam clues. Jugular venous distension is high yield on the board, the JVD. If JVD mention the question stem and think of RV failure, constrictive pericarditis, cardiac tamponade, tricuspid regurgitation, and tension pneumothorax. Pay attention to constrictive pericarditis and cardiac tamponade. Kussmaul signs, high yield as well. It's the paradoxical rise of JVP pressure during inspiration. Physiologically, inspiration drop in the pressure in the chest, so the JVP should drop. But this is paradoxical. The presence of Kussmaul's rule out cardiac tamponade. When you see Kussmaul or the description of Kussmaul's, then it's not tamponade or tension pneumothorax. That's out of the picture. Pulsus paradox, on the other hand, the exaggerated fall in systolic blood pressure more than 10 millimeter Hg during inspiration. It's the presence of that. That means they are talking either about tamponade or tension pneumothorax. Of course, sometimes massive PE, severe COPD, but I think this is the high yield. When you see pulsus paradoxus, look at the stem and see, is it tamponade or tension pneumothorax? It rules out other causes, not constrictive pericarditis or other causes of JVD. So tamponade, now we know JVD, pulsus paradoxus, and a risk factor of tamponade, malignancy, trauma, cardiac surgery, stat echo, and emergent pericardiocentesis. Tension pneumothorax, again, similar to tamponade, you have JVD and pulsus paradoxus. Of course, the clinical context is these patients usually unstable with severe dyspnea, absent breath sounds on the affected sides, SAT chest X-ray, and needle decompression. Constrictive pericarditis, they have JVD plus Kussmaul signs, plus pericardial knock, and signs of RV failure, peripheral edema, risk factors, of course, radiation, previous cardiac surgery like CABG, TB, echocardiogram as initial step diagnosis. Usually remember it's medical management first with diuretic. If that doesn't work, we move to pericardectomy. RV infarction, remember in the context of inferior wall STEMI, the presence of JVD and usually clear lungs, this raises the possibility of acute RV infarction, acute RV failure. Stat echo, remember if they are hypotensive, give fluids and avoid nitrites and diuretics and anything that can decrease the preload. I put amyloid here because it may come on the exam. It's one of the causes of right-sided, actually biventricular failure, but the right side usually failure predominates. Usually we diagnose with biopsy of myocardium or abdominal fat for diagnosis, and the treatment is supportive mainly. Any advanced treatment of amyloids will not be, it's out of the scope of our exam. All right, the Valsalva and standing preload changes, remember, affect all murmur intensity proportionally except in MVP, mitral valve prolapse, and hypertrophic cardiomyopathy. Valsalva and standing decrease preload, less flow through the valves. Less flow means softer murmur, except in hypertrophic cardiomyopathy and MVM. The left ventricular size decreases with decreased preload, worsen the murmurs here. So, okay, if the question mentions a louder murmur with Valsalva and standing, decreased preload, this is either they talk about hypertrophic cardiomyopathy or mitral valve prolapse. Of course, this will decide the young patient decrescendo murmur best heard at the left lower sternal border. And here there is a mid-systolic click followed by mid to late systolic murmur. The click is classic for MVP. Remember that preload changes affect left and right-sided murmur, and squatting increases both preload and afterload, but preload effects dominates. So preload effects here, preload will increase the preload, right? The squatting will increase the preload, which means increase the flow in the valves, increase the intensity of all murmurs except in hypertrophic cardiomyopathy and MVP. They behave differently. Let's talk about hand grip and vasoconstrictors. They increase the afterload and increase systemic vascular resistance. Regurgitant murmurs gets louder, MR, AR, VSD. And and the outflow and obstruction murmur gets softer, AS, aortic stenosis and hypertrophic cardiomyopathy. MVP loves hypertrophic cardiomyopathy. It goes with it anywhere, so it gets softer. You notice here that it no effect on mitral stenosis or right-sided murmur with changes in afterload. It's mainly a left-sided issue, but again, it does not affect mitral stenosis because we're talking about systemic afterload. We're not talking about pulmonary vascular resistance here. Very important to differentiate between aortic stenosis and hypertrophic cardiomyopathy. You don't need to memorize really. Young patients mainly talk about hypertrophic cardiomyopathy, but remember there is a bicuspid aortic valve. So young may not be able to completely differentiate, but older patients almost always talk about aortic stenosis. Both crescendo decrescendo is not helping, so it's ejection systolic murmur. But look at the right upper sternal border, aortic stenosis. Left lower sternal border, it's hypertrophic cardiomyopathy. There is radiation to the carotid, no radiation here. And that can be enough really to have the distinction between the two murmurs. But remember the Valsalva. If you know the Valsalva standing things, then it's easy. Remember, aortic stenosis follow the general rule. The intensity goes down. Valsalva decrease preload, flow through the aortic valve decrease, murmur decrease. The hypertrophic cardiomyopathy is the opposite. Early diastolic murmur, that's aortic regurgitation the bores until proven otherwise. The backflow of the blood back into the ventricle. The bounding peripheral pulses are really, if you see bounding peripheral pulses, this is aortic regurgitation until proven otherwise. Diastolic decrescendo murmur along the right or left lower sternal border. Remember that. And also very important, bicuspid can cause both aortic stenosis, aortic insufficiency or regurgitation, or both. Holosystolic murmurs. When we say holosystolic murmurs, we talk about mitral regurgitation, VSD, tricuspid regurgitation. With VSD, if you see the harsh word, that's VSD until proven otherwise, and you see thrill, that confirm it. Blowing, best here to the apex, that's mitral regurgitation. And tricuspid regurgitation, most of the time, they will mention louder with inspiration. Remember the louder. Mitral regurgitation louder with hand grip, because after load. Here louder with inspiration, tricuspid regurgitation. And with VSD, the smaller the defect, the louder the murmur. The larger the defect, the softer the murmur. If the question mentioned MR and the settings of acute MI and acute pulmonary edema, thinks of papillary muscle rupture, immediate echo and surgery. If TR, tricuspid regurgitation, develop acutely after inferior wall MI, think of RV infarction or papillary muscle involvement as well, the same thing. TR, tricuspid regurgitation, flushing, diarrhea, and pulmonic stenosis, think carcinoid heart, echocardiogram, and treat the tumor, of course, which we'll come to later on. The mid-systolic click is classic for MVP. MVP remain the most common cause of mitral regurgitation, although most of them has no or minimal MR. Also, fixed S2 splitting is classic for atrial septal defects. Because remember, S2 that doesn't split or doesn't change with respiration, always splits same with in inspiration and expiration. So that's the fixed splitting. And if it's mentioned, that's ASD, which lead to left to right atrial shunt and then atrial enlargement, right atrial enlargement on RVH. So look for incomplete right bundle branch block that may present right and atrial and RVH criteria. Opening snap is classic for mitral stenosis. Rheumatic fever remain the most common cause of mitral stenosis. Treatment is not easy with this disease. Atrial fibrillation is common and should be anticoagulated with warfarin. Do not use direct oral anticoagulant with AFib in mitral stenosis. Also, atrial myxoma mimics mitral stenosis, often accompanied by constitutional symptoms. So, atrial myxoma mimic mitral stenosis murmurs. Remember that when you see that constitutional symptoms and embolic events, think of atrial myxoma. Of course, we're just talking about the physical exam part of this, and some of them will talk about the treatment, but we will mention them again, especially the treatment. The S3 and S4, of course, high yield, early diastolic sound right after S2. If you see S3, sometimes they will not say S3, so they'll say an early diastolic sounds right after S2. If mentioned, that means volume overload in the right clinical context, symptomatic and typically above 40. Why I'm saying that? Because S3 in young, less than 40, and asymptomatic person, this is physiologic, and sometimes even in pregnancy. S4 in general is never normal, and it's absent in atrial fibrillation. Why? Because it's from the atrial contraction against stiff, non-compliant ventricle. S4 plus chest pain, think acute MI. S4 plus hypercardiomyopathy. This is a common association and usually present with a lot of hypercardiomyopathy patients. S4 in elderly with hypertension plus dyspnea, think heart failure with preserved ejection fraction. Blood pressure clues, wide pulse pressure. Remember, think of aortic regurgitation where there is increase in systolic and decrease in diastolic blood pressure. Narrow pulse pressure, thinks of aortic stenosis, also tamponade and cardiogenic shock. Acute blood pressure differential between arms, thinks of aortic dissection. Chronic blood pressure differential between arms plus arm fatigue, dizziness with the use of that arm, think of subclavian steal from proximal subclavian artery stenosis. Ankle brachial index above 0.9, think of peripheral arterial disease. higher blood pressure in the arm than legs, with a gradient more than 20 mm Hg plus radiofemoral delay, classic for aortic coarctation, where 75% of patients have hypertension and 50% have bicuspid aortic valve, and remember it's associated with Turner syndrome. Orthostatic hypotension, a drop more than equal or more than 20 in diastolic, in systolic, or equal or more than 10 in diastolic blood pressure within 3 minutes. The 3 minutes is very important. Even in real world settings, most they don't wait for the 3 minutes before rechecking the blood pressure when they stand. Also, pay attention to the pseudo hypertension. If the question mentioned, while using the cuff, despite the high cuff pressure, the radial artery is still palpable, that means they have falsely elevated blood pressure, pseudo hypertension, elderly, diabetic, and CKD because of the calcified arteries. The pressure cannot squeeze them enough. So consider wrist blood pressure or direct arterial measurements. Pulse rate clues, you can, very important, you can skim over them, but remember the atrial flutter, probably you know that if the rate around 150, think of atrial flutter 2 to 1, and you can skim the SVT like this range, AFib, but very important this one, the irregular wide complex tachycardia. AFib is usually very fast rhythm and very dangerous, and it's irregular wide complex. Avoid AV nodal blockers in these things. Okay, that's very important to remember. An eye exam clues: xanthelasma, familial hyperlipidemia, increase the risk of premature coronary disease. You need aggressive management here. Blue sclera, hearing loss. I don't know if it will appear, but remember osteogenesis imperfecta, aortic root dilatation, and aortic regurgitation, similar to the Marfan syndrome, which is usually associated with MVP as well. Upward lens subluxation, tall, thin patients. Skin, and excuse me for these little things, I forgot to fix them, but look at the large fonts here, large points. Edema, ascites, jaundice, right heart failure with hepatic congestion. Tendon xanthoma similar to xanthelasmas, and the Achilles and knuckles, familial hypercholesterolemia. We need aggressive management as well. You probably know the bronze skin and diabetes and cardiomyopathy. This is hemochromatosis. Malar flush, pinkish purple cheeks, mitral stenosis with low cardiac output. Differential cyanosis, very important. Remember, if there is the question mentioned that the lower extremity cyanosis more than the upper extremities, thinks of PDA with Eisenmenger phenomena. Osler nodes, painful fingertips, Janeway lesions, painless palms and soles, splinter hemorrhage, thinks of endocarditis. Quinky sign, I've never seen it, nail bed pulsations, thinks of severe AR, goiter, tremor, atrial fibrillation, check TSH, think of hypothyroidism, clubbing and cyanosis, thinks of cyanotic congenital heart disease or Eisenmenger syndrome. Additional findings, pulsatile liver, that means severe TR, tricuspid regurgitation. And remember Turner syndrome, very important, short stature, webbed neck, widely spaced nipples, Turner syndrome. And the Marfan syndrome, the tall habits with long limbs, arm spans, you probably know that. It can cause aortic root and aortic regurgitation, also associated with MVP. If you would like to receive the PDF document of this presentation, this is available for paid Substack subscribers and the member channel, YouTube channel. Make sure to sign up for those, and then you will receive a link for the PDF document of each presentation right before the episode even is released. Thanks for watching, and I'll see you soon.